Χαίρομαι που βλέπω το ακροατήριο. Καταρχήν συγχαρητήρια για το συνέδριο και εύχομαι να γίνει θεσμός πια αυτό. Η αρχή είναι πάντα δύσκολη. Μετά ευχαριστώ πάρα πολύ τους διοργανωτές, ιδιαίτερα τον καθηγητή Ευσταθόπουλο και τον καθηγητή Καραΐσκο που με καλέσανε να έρθω στην Ελλάδα πάλι να μιλήσω για κάτι το οποίο είναι πάρα πολύ ενδιαφέρον τα τελευταία χρόνια, αν και το φαινόμενο έχει παρατηρηθεί στο παρελθόν, αλλά δεν του δώσαμε πολύ μεγάλη σημασία και ξαναβγήκε πάλι στην επιφάνεια πριν μερικά χρόνια. Δεν θα επιχειρήσω να συνεχίσω την ομιλία μου στα ελληνικά, όπως έκανε ο κύριος Σταθάκης, θα το γυρίσω στα αγγλικά. Έχω δύο προβλήματα. Το ένα είναι μεγαλύτερο, το άλλο είναι μικρότερο. Το μεγάλο πρόβλημα είναι ότι δεν ξέρω την ορολογία στα ελληνικά και όταν με ρωτήσανε τι είναι η τράπεζα θεραπείας, δεν ήξερα, ξέρω δύο τράπεζες. Την Αγία Τράπεζα που έχουμε στις εκκλησίες μας και την τράπεζα που πας και καταθέτηση σου παίρνει τα χρήματα. Οπότε αυτό είναι ένα παράδειγμα, δεν θα το... Το δεύτερο πρόβλημα είναι και τα αγγλικά μου δεν είναι πολύ καλά γιατί δεν έχω γεννηθεί στο εξωτερικό. Οπότε από τα δύο κακά θα πάρω το... Λοιπόν, disclosure, θα μιλήσω λίγο για το καινούριο AAPM Task Group 359, το οποίο το βάλαμε μαζί για να απαντήσουμε ένα ερώτημα που έχει να κάνει με δοσιμετρία flash. Θα μιλήσω λίγο για το flash. Ποιοι από εσάς γνωρίζουν λίγο από flash, τι είναι το flash effect? Εντάξει, μερικά χέρια βλέπω. Τα υπόλοιπα, όχι ότι θα το μάθετε από μένα, αλλά θα αναφερθώ λίγο. Λοιπόν, so, a couple of definitions and the scope of the presentation. The treatment modality I'm going to talk about is termed as flash. In reality, is ultra-high dose rate radiation therapy. Ultra-high dose rate, the rate of radiation is very high, and the dose delivered is very high, and the dose in the pulse that the machine produces is very high. I'm going to make a connection without even knowing it with a couple of things that the first speaker in this session brought up. The ultra-high dose provides some detail of the type of beam that you use for delivery. The flash refers to time scale, not the production of the beam, but the time scale of delivery. So the delivery is done instantaneously in a flash. The whole dose is given right there. But I'm going to talk about the dosimetry of it. Actually, I'm going to talk about the lack of dosimetry, which is, for me, it's kind of scary. But before I go to dosimetry, for people that are not aware, radiation doses, ultra-high dose rates, provide similar tumor control, but they lower the normal tissue response. In other words, you treat a tumor with flash, it responds the same way that it responds with conventional fractionation, conventional delivery, but the normal tissues are more protected compared to standard dosimetry. Flash dose rates in general are defined with doses over 40 gray per second. Not centigrade, 40 gray per second. The conventional dose rates are between 0.1 and 1 gray per second, maybe a gray and a half per second, just to see the difference. Down on the bottom here, there are examples of dose rates of delivering 10 gray, and when you exceed the 30 gray per second and you go to 40, 60, 100, 500 gray per second to deliver this 10 gray, you will see that the parameter that people used on their experiment to show whether the response in conventional and flash dose rates is different, you will see that you have more positive results. I'm not going to explain what the recognition ratio is, but the higher it is, the better for the patient is. With flash dose rates, you get a high recognition ratio compared to the conventional dose rates. So same dose, 10 gray, given with different dose rates, okay? A second one, I have here on the left some of our experiments in flash, and on the right-hand side, other people. The blue is for normal radiation. I'm sorry, for non-radiation, so it's your control. For standard radiation, and for flash is the green. You will see that the proliferation, preservation of cells after they were irradiated with standard fractionation and flash fractionation, the flash fractionation, it's closer to non-irradiating the tissue at all. So the normal tissue preservation is better preserved if you deliver it with flash. And the skin protection is better preserved, which is down here, green, if you deliver it with flash compared to no radiation at all, almost identical. So if I treat skin with flash, it's as if I didn't touch it with radiation, but if I deliver it with standard fractionation, same dose, standard dose rate, you see you have skin effects. Okay, so this is how flash effect works, but I'm not going to talk about that. Just a little bit to give you. I want to talk about dosimetry. So how can we accurately calibrate a proton or electron beam in ultra-high dose rate mode? Why proton and electron? Because today, the easiest way or the available ways to produce flash beams is with proton accelerators and with modified Linacs or dedicated electron machines that companies make to deliver ultra-high dose rates. We don't have photon machines yet that they deliver flash X-rays. Do we have reference dosimetry standards for ultra-high dose rate? First speaker talked about the TRS-498, the TRS-483 of IAEA. We have task group 51 in the United States. We're using something similar to the 498 to calibrate our photons, our electrons, our FFFs. Then we jumped into flash. We start doing experiments. There are clinical trials starting in the United States for flash. And I ask people, do you know how to calibrate your machine in flash mode? And they look at me and they say, well, I know how to validate it. We don't validate. We do absolute calibration first based on reference standards. Then we validate, and then we treat. So do we have appropriate detectors for this particular modality? Remember, reference dosimetry, when I talk about reference dosimetry, I mean absolute calibration. The reference speaks of the chamber we're using, the equipment we're using has a calibration factor that refers to primary standards. That's where the reference goes, is not reference calibration, not output factors. Do we really have dosimetry for flash beams? I don't think we have. Okay? So we have some things that we know, and we have some things that we do not know. So we know what we know so far. We know what we do not know. We don't know what we don't know. Okay, right? I mean, I don't know what I don't know. There's a fourth category. We have unknowns, knowns, okay, in dosimetry techniques. So flash dosimetry is not something that necessarily needs to be inventing, because I can make a machine that produces specific pulses with specific number of charges any way I like it based on the technology that we have today. Typically, as I said, 40 gray per second and above is what flash mode is, in comparison with, for example, the standard dose rates. But flash mode machines used in general industry have been out there for a long time. If you look at industrial processing, they're using very high dose rates with high pulses in order to sterilize materials, in order to neutralize chemicals in industry. And if you talk to these individuals, they do have some type of dosimetry that they're doing, be it not as accurate as we know that we need in radiotherapy. However, they do have it. The unknown knowns is that we need a radiation source with high instantaneous beam intensity. Bremsstrahlung, it's a problem in order to produce photons in high intensities. Particle beams, though, are the real options that we have. You can hack your LINAC, purpose-built high-dose rate machines, proton facilities, all those things can produce flash. We know what we do not know. We have very good protocols. So back to basics, either TRS-398, don't look at the time, TRS-98, you have a calibration factor, you have a beam quality factor, and you have your corrected charge for many things of your ionization chamber. If I take now standard beam and I move it to flash, I have the same calibration factor that I'm using because it's relative to cobalt. Nothing new there. But this particular factor here, it has to be beam quality. Be it that the beam energy is the same, if you have 6 MeV electrons in flash mode, 6 MeV, 6 MeV. However, there is the high dose rate per pulse, or dose per pulse, that comes into play. So I need to correct both the KQ and my reading appropriately. So I'm going to multiply it by an overall correction factor. The first speaker spoke about that approach. But wait, we've done this already for the small field dosimetry. So can I go the same way? Not the same factors. I need my new flash factors. But because dose is equal, any way you look at it, what are those factors coming? Those factors should be coming from. Those factors, they have to be the polarity correction, the electrometer correction, field side dependence, additional factors, and the most important, ion recombination. Ion recombination is what breaks the deal with flash. It's a big one. Why? Because we do not have models of ion recombination for very high dose rates and very high dose per pulse. Do we need new models to describe that? Those factors are LET, low energy, linear energy transfer dependent. The beam structure also is very important. Let me give you examples. If I look at protons with very high pulses, that they are very close to each other, the beam structures looks like this. It's almost like continuous. It's almost like cobalt, because they're very, very close, and you can pack those next to each other. So the pulse structure phenomenon doesn't come very evident. But if you look at your LINAC, it looks like this. And further on, because of the interest of time, those structures in here, they have microstructures. That's where the dose is coming. That's where you pack all your dose for every pulse. I remind you that common ion chambers, whether parallel plate chambers or Farmer chambers, they have about 10 to 20 microsecond response time. You're looking at picoseconds here and microseconds there. Okay? So keep that in mind. So that correction is very, very important. And also when you have proton beam scanning, your beam is voxelized. So you need a different approach to determine what the dose rate is. Okay? So all those things, they need to be investigated when you have reference dosimetry. Example, when I have a chamber, ion chamber, for beam monitoring in a proton machine that I tried, I noticed that I have a polarity of over 20%, and I have an ion recombination of about 40% in flash. Okay? We're not talking about 2 or 3 or 4% here. We're talking about a bigger factor that you need to be aware of. So, an unknown. I don't know what I don't know, so I need to do research, because research is what I'm doing when I don't know what I'm doing. Okay? So we need to look at all this. So we have machines that we can produce flash in a dirty way by hacking them. A lot of people have done this. And we can investigate those. I'm going to go a little bit more quick. And then we have machines that they come from the company, like Mobitron, that will give you flash beam in your clinic, not only to treat patients, but also to do your investigations. And of course, in few places, including Penn, we have protons that we do flash. So, because of those dosimetry open questions and some others, we decided about 1.5 years ago to put together Task Group 359 at the AAPM. It's a true international collaboration. It's, the membership has a lot of people of the AAPM, has almost equal numbers of authors from IFOMP, from Estro ACROP, and from Australian group. Just to acknowledge all these individuals, their nice faces and names are here, more here, more here, more here. Summary. So this is really a true project. This is something that we need to really put the horse first and the cart after. The Americans, they say, we put the horse after the cart, so the cart goes. Έτσι, πρώτα πάει η άμαξα και μετά πάει το άλογο. Πρέπει να βάλουμε το άλογο να τραβάει την άμαξα. Το άλογο είναι η σωστή δοσιμετρία. How much do we know? What assumptions we need to make? What models we need to use? And then, are we talking about the average dose rate? Or we're talking about the instantaneous dose rate? In other words, I'm putting also another question. What is the correct language we need to do? Some people say, I gave 70 gray in a second. That doesn't mean too much to me. What kind of beam? I use protons. What kind of beam structure do you have? Is it a pulsed beam? Is it a continuous beam? Because the ion recombination correction factor, it depends not only on the dose rate, but on the dose per pulse. So if I don't know that, I don't know what you're talking about. So I cannot take your 70 gray with your beam that you didn't tell me what it is and compare it with the 70 gray that I gave in a second in my beam that I know what it is.
Παρακαλώ, ολοκληρώστε, κύριε Μιχαηλίδη.
Ολοκλήρωσα. Thank you.